Welcome back, everybody. I hope you enjoyed your lunch. I think you'll agree this morning's session was very informative, and I'm sure you'll find this afternoon's session equally energising. I'd just like to introduce our next speaker. On my right is Dr. John Monaghan, who is a consultant obstetrician and gynaecologist with more than 30 years of experience in maternal health care. Dr. Monaghan graduated from Trinity College Dublin, trained in Ireland, the UK and Nigeria, and is now a consultant at Portiuncula Hospital, Ballinasloe, County Galway. He is also a member of the Irish Medical Council. Dr. Monaghan will discuss standards of maternal care and rates of maternal mortality in Ireland in his presentation, A Safe Place, Achieving Excellence in Irish Maternal Health Care. Please join me in giving a very warm welcome to Dr. John Monaghan.
Thank you, Aoife. I'll get that picture off. Somebody said it's not the best slot. You know, immediately after lunch, people get a bit sleepy and that sort of thing. One time I had to give a talk down in Galway, and it was later in the evening at about 7 o'clock, and 2 people turned up. And one of them fell asleep. And the other fellow didn't fall asleep because he knew the other fellow had fallen asleep. And so I did my little monologue, as it turned out, and we got through it. So I won't be offended if you drop off. But I reckon probably the only way to maybe keep you awake is to try and start a bit of a row. So that's part of my intention. So also the light is not too favourable, but I'll try and explain the slides if there's any data that you can't see. That's Portiuncula Hospital, which is a small hospital delivering 2,200 babies in the west of Ireland. And it's just a general hospital. I wasn't quite sure why I was asked to give this talk, because I don't claim to be an expert on maternal mortality. But when I think about it, there probably isn't any expert on maternal mortality in Ireland, because it was never really considered to be a problem. I did see Professor Richard Green just before lunch and asked him if he'd like to give the talk, because he would probably be the expert, but he declined. He might like to comment later if there are any questions. So I got a fairly general topic, and I suppose the question is, how good is it, or is it good and safe to have a baby in Ireland? So just briefly, if we look at that's a graph. It starts in 1976, which is the year I graduated. Now, when you get to a certain stage in life, you realise that looking back might be longer than looking forward. So I tend to look on the history of the world, or at least the medical world, as what happened since I graduated from Trinity College in 1976. I see Professor Bonner in the audience. I think he arrived in Trinity College in 1976 or 1975 and was there to examine me in my finals. I don't think he gave me a great mark either, but it was enough to get through. Since 1976, perinatal, that is stillbirths and births in the first week in life, stillbirths and neonatal deaths, are, as you can see from the graph, have fallen dramatically. There is no need to really comment on that, and it's a bit outside the subject matter. One thing that interests me a little bit is that intrapartum death, or the death of a baby in labour, has almost disappeared as a cause of death. It more or less no longer exists. And that's interesting, and it's quite recent. One thing that hasn't changed at all is the incidence of neonatal encephalopathy, or babies that show signs of brain damage in the newborn period. These are figures from the National Maternity Hospital in Dublin, 76 to 85, 1986, 1996 to 2005. You probably can't see the figures, but they're 2.153, 2.136, and so on. They're within, you have to go to the second decimal point before you see any change in the incidence of neonatal encephalopathy. And that's a mystery which has yet to be solved in obstetrics or paediatrics. We tend to feel fairly good about our maternal mortality in Ireland. We think that we have something better than other places. And if you were to say, well, why would we think that, or why would we be entitled to think that, I think it's down to one man. This man here, you obviously wasn't around today or yesterday, name of Bartholomew Moss, is the founder of the Rotunda Hospital in Dublin. Bartholomew Moss got married at the age of 26. He originally was from Portlaoise, then called Maryborough. And in 1734, at the age of 26, he got married to a woman called Elizabeth Mallory, who was from down that part of the world as well. It's not recorded, but I think one of the reasons why we may have been so early in on maternal death was that Elizabeth Mallory died 3 years later, shortly after the delivery of her first child, as did her son. After that, Bartholomew Moss went travelling around Europe. He was very influenced, I think, by what he saw in Paris. And in 1745, he bought a theatre in George's Lane in Dublin. The theatre had just been closed down for putting on lewd plays. And he opened the first maternity hospital, the first maternity delivery facility in the British Isles. And in the first year, they delivered 208 babies, I think it's babies, and one mother died, which seems incredibly good. In 1757, the Rotunda Hospital opened, and in that year 454 babies were born, and there were 8 maternal deaths. He was elected master for life. Interestingly, he was also allowed to have 2 assistants, both male midwives, and that pattern of master and assistant master has more or less continued until the present day, and would be the way that many Irish obstetricians, or most even, may have been trained. However, master for life wasn't to be for very long, because he died 2 years later at the young age of 45. The other 2 hospitals in Dublin, which are also very old, would probably have been modelled on the Rotunda Hospital. People came from all over the world to see it, because it was the first purpose-built maternity hospital in the world. Now, is it a good place for a mother to have a baby in Ireland? Traditionally, it has often been said, particularly by pro-life advocates, that Ireland is the safest place in the world to have a baby. I'm afraid the light is rather severe here, so I might have to do a bit of pointing. But according to these figures from 2010, published in The Lancet, Italy is number 1, Sweden number 2, Australia, Ireland is number 6, with a maternal mortality of 5.7 per 100,000 births. The UK, because it's an English publication, this I think it was taken from some English, it is 8.2. The United States, I can't see it in the bottom there, I think it's 16.7, something of that order. So we do get up fairly high in the league tables. Is there anything new about maternal mortality? And I think there is something new, and it was clarified by this publication, The Lancet, 31st of March this year. Published, Susan Bewley was the author, she's a well-known obstetrician in London, suggesting or claiming that maternal mortality in the London area had doubled in the last 5 years, and wanting to know why. The paper goes on to say that maternal mortality has risen in Austria, Canada, Denmark, the Netherlands, Norway and the USA, and asks, why could this be happening? The proposed suggestions are the extremes of maternal age, obesity, social deprivation, black and minority ethnicity, late access to health care, in vitro fertilisation and multiple pregnancy. Obesity is probably, yes, obesity is there. So this is a very interesting observation, and has the rising death rates in apparently developed Western countries causes quite a lot of discussion. Now, there's one thing that I need to explain to you, if I go back to these figures. The figure of 5.7 per annum would refer to direct maternal deaths as recorded by the Central Statistics Office. And that may not exactly correspond to all of the maternal deaths, but the same criticism, if you like, would apply to all of the others as well, including the UK figures. It's not that we're cooking the books, but direct and indirect mortality are important. It's important to distinguish between them, and Obviously, a direct is somebody who dies from postpartum hemorrhage or eclampsia or something like that. An indirect could be a woman with heart disease exacerbated by pregnancy, or it could be a car accident or an explosion or something like that. If you remember the Omagh bombing, a woman expecting twins was killed during that. So is there any source that we can use in Ireland for to find out the total maternal mortality as opposed to direct? And all of the 3 maternity hospitals have published reports probably for over a century and always record maternal deaths. In fact, I don't know whether you can see that or not. In many of the reports, the master would take the page for maternal mortality, which is on the left here, and it says there are no maternal deaths. And the page is left blank as a sort of a little celebration that we got away without any mothers dying this year. That's the pretty pleased-looking doctor on the far side there. Now, if we look at the question of maternal mortality rising or not, I estimate from the reports that the maternal mortality in the 3 Dublin hospitals between 1991 and 2000 was 7.3 per 100,000, and between 2001 and 2010 it was 8.6. So it certainly hasn't doubled. There may be a small rise, and some of those factors, such as obesity and so on, are going to be operating. Perhaps multiple pregnancies and so on are going to be operating here as the same as they do in every other country. So does that reflect the true maternal mortality and rate in the country? I think it's an overestimate, because if you look at the reports, there are several transfers in from other hospitals, maybe hospitals like mine, so that's going to give a higher figure than the national figure as a whole, but it's the best we have. By comparison, maybe there was a publication in the International Journal of Obstetrics and Gynaecology, February of this year, from the Coombe Hospital, looking at the risk of death from associated with the rising caesarean section rate, and it showed that their overall maternal mortality rate over the last 15 years was a stunning 2.7 per 100,000 births, which is amazing. Now, if you look at those figures that I'm talking about, the Irish figures, my own breakdown on the causes is very approximate, may not be very useful, but just in the context of this meeting, brain hemorrhage 10, cancers 8, hemorrhage 7, I'm mixing up direct and indirect here, sepsis 7, preeclampsia HELP 5, cardiac 5, pulmonary embolism 4, epilepsy 4, traffic accidents 4, anything else than that is 1 or 2. So those figures are probably rather similar. It suggests possibly to me that indirect factors might be more important than we think. I just looked at the cancers since the speaker was on this morning. There were 8 cancers, 3 brain, 2 melanoma, and 1 each breast, colon, and lymphoma. The only good thing to report is that the English figures, which incorporate direct and indirect, Ireland has gone into that. And in the 2013 report, these reports are produced every 3 years. In the 2013 report, Ireland will be included, so we will get a true figure for indirect and direct. So what does the latest 2011 report from the UK say with regard to deaths? It gives a total of 11.3 per 100,000, direct 4, and the CSO figures, that's the figures that we will be doing for Ireland, this is the English CSO, gives a figure of 6.76. Causes, the same as I've just said, maybe slightly jumbled around. Sepsis infection has emerged as the single biggest cause, particularly the re-emergence of Group A hemolytic streptococcus, childbed fever, which I'm sure Bartholomew Moss must have dealt with because it's been known for 200 years, and that's emerged as the single biggest cause. Preeclampsia, thrombosis, embolism, amniotic fluid embolism, ectopic pregnancy, and then cardiac neurological. There's not much in that. The reports tend to adopt a sort of a theme, something to take out of this that will help in the future, and the theme was back to basics. In other words, implying that many maternal deaths were a result of simple poor clinical performance in the simplest way. It lists the failure to pay attention to a woman with fever and sore throat, abdominal pain, headache, breathlessness, mental health issues, and it also talks about communication between staff. So if we say that Ireland is sort of in the region of 8, USA 24, that may be too high. In global context, Chad has a maternal mortality rate of 1,200 per 100,000, so it's a huge difference. The figure we got for Kenya this morning was 488, and Sudan is 750. Now, why did I say Sudan? Why did I pick Sudan of all the 181 countries that are listed? There was a publication in the British Journal of Obstetrics and Gynaecology last year about the Cork Omdurman, that's the name of the hospital in Sudan, Partnership Project, or COP, which started around 2000 or 2001. Basically, a group of Irish-trained Sudanese doctors and the Sudanese government said, we're going to try and do something about maternal mortality. And I think many of the doctors were asked to come back by this Department of Health in Sudan to try and address this problem. The Irish government put up €165,000, which was matched by an equivalent amount from Sudan. The Cork Fire Service refurbished an ambulance. There was training offered in Sudan for obstetrics and neonatology. Equipment was sent out in 4 containers from the closure of St Finbarr's and Ernvin hospitals in Cork. And a management company called Prospectus provided gratis governance advice. This hospital is the largest hospital in Sudan, 24,000 births a year, dwarfs anything in Ireland. In 2001 they had 32 maternal deaths. In 2007 they had 7 maternal deaths, which must represent one of the best investments ever, if you can put 165,000 into saving probably a couple of hundred lives. The causes of maternal mortality then in Sudan are listed in this article. You can see I'm repeating myself: hypertension, hemorrhage. There's one difference: hepatitis, liver failure, sepsis and embolism. They're all the same. The key message out of this paper was that 4 things had changed maternal mortality: hypertension, treatment with magnesium sulfate, improved hygiene and use of antibiotics. Much of the €165,000 by 2 was spent on establishing a small laboratory to provide safe transfusion, and the use of misoprostol for postpartum hemorrhage or prevention of postpartum hemorrhage. We use oxytocin in this country. It has to be kept in a fridge. You can't have fridges available all the time in a country where you may have power cuts and so on. So those simple measures seem to have had a huge effect. Moving on, I don't know how I'm doing on the time now, but I'm interested in the question of the difference between Ireland and the UK, which has historically been claimed. And I'm suggesting that a possible reason for the difference in maternal mortality might be recruitment. In 2007, I think this was, a report was produced in the College of Obstetricians, and it says, I'll read it on the top: recruitment of UK graduates to the specialty of obstetrics and gynaecology has been falling to dangerously low levels over the last few decades. In 2002, only 2.8% of graduates chose it. By gender, it was 4.1% women and 0.8% men. In other words, both have dropped, but men much more than women, which is causing a little bit of concern. So, recruitment. If you look at the career choices of medical graduates in the UK, starting on the bottom, the smallest number of students who go into obstetrics and gynaecology is in Leeds, then Cambridge and so on. And on the top right, you come to the most popular, and the medical school with the most graduates going into obstetrics and gynaecology is Queen's University in Belfast. If we take a look at maternal mortality, this is the figures for 2003, 2007, maternal in the different health regions in the UK. The one with this figure is 8, and it's Northern Ireland has the lowest maternal mortality for that 5-year period. So they seem to get more graduates and more live mothers. I think I can show you the problem of recruitment. There's a hospital in Harrow, north of England, north of London, called Northwick Park, which many Irish graduates have gone to, many distinguished Irish graduates, and many midwives have trained there, and it would have had a history of quite a close relationship with Ireland in general. However, something went wrong in Northwick Park Hospital. Between the years April 2002 and April 2005, there were 10 maternal deaths. Northwick Park delivers about 5,000 babies, smaller than any of the Dublin hospitals. If this were translated into Dublin, it would have been 60 maternal deaths. In fact, there were 6 in the 3-year period, or roughly 6. These 10 mothers that died, interestingly, only 1 baby was lost. The 9 live children were left behind. And I think that one case, which is the second last case there, and you can't read that, but I'll give you a brief summary of the case. A woman came in, she was found to be anemic at 36 weeks. She was transferred with 2 units of blood, admitted at term for induction of labour. started to develop decelerations, and it was decided to do a caesarean section at about 5 o'clock in the afternoon. The caesarean section was done by an SPR who then went off duty. Cover was taken over by a locum registrar who didn't know anything about the woman, and subsequently it emerged didn't know anything about her having a blood transfusion or having a low hemoglobin. The woman was kept in the theatre because the anaesthetist wasn't happy with her welfare. She started to have fluctuating blood pressure. Her levels of consciousness started to vary, and the locum registrar was called and was quite concerned about her. Rang the consultant. She rang the wrong consultant. The consultant wasn't on duty, and she rang the locum consultant who was on duty. Locum consultant said to get her hemoglobin down, and didn't say anything much more. The anaesthetist, meanwhile, was getting increasingly concerned, tried to get blood cross-matched. 2 hours later, the registrar rang again to the locum consultant to say that the woman's abdominal girth appeared to be increasing. Her blood pressure was fluctuating widely, and she was semi-conscious. The consultant said that he thought she should have a blood transfusion. So the woman died about an hour later. It turned out that her uterus was full of blood. Her hemoglobin shortly before she died came back as 2 grams, I think, something like that. So the report, this locum issue goes through many of the other deaths, and the report makes 2 very specific things about communication between midwifery and doctors and doctors and doctors, the presence of locum staff all over the place, morale seemed to be poor in the unit, and the absence of the involvement of consultants in the care of these 10 women who died. Now, Northwick Park was put on some sort of special measures. There were new consultants appointed, 20 new midwives appointed. Just goes to show you that if you do a bad job, you get resources. And it is now, I think its reputation is restored, but I recommend every trainee I meet to read this report. There is so much to learn that you can see yourself in some of the interactions and things that went wrong with these 10 women, most of whom died from hemorrhage. So I'm suggesting that recruitment is an issue. The last mother to die in our hospital was in 1984. I don't claim that we're very brilliant because of that, but I'm not aware of any mother dying after that either. But I think we have never had a problem with recruitment in Ireland in any case. Going back to Northern Ireland, with its high recruitment into obstetrics and its low maternal mortality, I asked myself what else is different between Northern Ireland and the UK. And I think there is only one difference that I'm aware of, and that is that the Abortion Act doesn't apply there. And that may be why graduates are attracted to work in obstetrics. There have been several stories, particularly in the UK, about more young doctors oppose abortions on ethical grounds. And the RCOG says that our current advanced training skills module attracts very few doctors, which does not bode well for the future. The director of family planning for the RCOG said, "You get no thanks for performing abortions, you get spat on. Who admits to friends at a dinner party that they're an abortionist? It is not a sexy area. It is a bog standard area of women's care." So I'm suggesting that it's nothing to do with religion or ethics. It's just that the prospect of abortion is sufficient to put many good graduates off practising obstetrics. I can move on from that. Just briefly turning to the United States, Dr. Bernard Nathanson, who used to run an abortion service in New York City, speaking after Roe versus Wade, said that in the abortion clinics in New York, the quality of the physician staff was, in a word, deplorable, consisting of an extraordinary variety of drunks, druggies, sadists, sexual molesters, just plain incompetence and medical losers. It remains true even today, this is in the late 90s, I think, 25 years later in America, that abortionists do tend to come from the lower order of the medical profession. So we have evidence of increasing conscientious refusal among young doctors for abortion. So what do you think we can do about that? Well, one suggestion is that we should get rid of conscientious objection. In a paper published in the New England Journal of Medicine, very well-known paper now, Julie Cantor, Conscientious Objection Gone Awry, says, "As the gatekeepers to medicine, physicians and other health providers have an obligation to choose specialties that are not moral minefields for them. Qualms about abortion, sterilisation and birth control, do not practice women's health. Believe that the human body should be buried intact, do not become a transplant surgeon. Morally opposed to pain medication because your religious beliefs demand suffering at the end of life, do not train to be an intensivist. Now, I don't know where that leaves me, but it certainly leaves me outside of the field of obstetrics. Now, I don't have any problem about bodies being buried intact. I don't have any problems. I don't believe in denying people pain relief. There's only one word in that whole paragraph I have a problem with personally, and that's abortion. But it's conflated with a group of other nonsensical statements to make me look ridiculous. Now, I want to go, I'm going to go into this just a little bit more in relation to the Irish Medical Council. Now, I'm a member of the Irish Medical Council, but I'm not speaking on behalf of the Medical Council, obviously. But I wanted to look just briefly at the ethical provisions or otherwise that might be available to a doctor who maybe he wants to bury everybody with their limbs intact. But in 2009, to my mind, the definition of an efficacious or ethical or well-behaved doctor, the patient-doctor relationship is a privileged one that depends on the patient's trust in the doctor's professionalism. Now, I don't know if you have a definition of professionalism to hand, but I don't. It seems to imply that you behave in some particular professional, maybe dignified way. The 2004 report was a little bit stronger in that it said ethical principles at the very foundation of our role as doctors. The potential damage to the bond of trust between doctor and patient is very great, and damage will occur if the ethical basis of practice is neglected. So our marker or our criteria for success appears to be professionalism. Likewise, in 2004, sorry, these slides are a bit slightly back front. The first one is 2004. Medical care must not be used as a tool of the state to be granted or withheld or altered in character under political pressure. I think that seems fair enough, but it's no longer in the ethics side. It is now doctors should act independently in the service of the patients and have a responsibility to advocate with the relevant authorities for appropriate healthcare resources and facilities. Now, my reading of that is that you cannot have the 2004 definition anymore, because the Minister has taken such powers on his or herself in the new Medical Practitioners Act that you couldn't write that and still be consonant with the law. So I'm not sure what professionalism is or what sort of guarantee it offers of good ethical behaviour. That might be an example of a professional-looking doctor. Another alternative view of a doctor is he's a highly trained technician daily exposed to exceptionally powerful material and spiritual temptations, or to survive intact the lure of the worldly temptations of the medical world, the uninterrupted flow of money, the drum fire of flattery, and the inebriating effects of special privilege. I think that's not without some merit as a description of some medical practitioners I know, maybe even myself. Finally, in relation to the ethics guide, Conscientious Objection, number 10, one says, as a doctor, you must not allow your personal moral standards to influence your treatment of patients. I don't know if anybody could stand up and say, well, what other moral standards would you use in treating patients? Do you get it from a kit out of a cornflakes box? There isn't any other standard you can bring to treating patients except your own moral standards. So I tried to launch a sort of slightly I was a bit stung by the the proposal to abolish conscientious objection in particular to abortion. And around the time that this debate was going on, there was an article in the British Medical Journal. I don't know if you can read that, but it deals with interrogating detainees in Guantanamo Bay. Something very interesting happened there. And the article says the contrasting ethical policies of physicians and psychologists concerning the interrogation of detainees. The American Psychological Association in 2002 adopted a new enforceable standard, allowing their members to set aside any ethical responsibilities if they were not reconcilable with government authority. Military psychologists were enlisted to help develop more aggressive interrogation techniques, including snarling dogs, forced nudity, long periods of standing against terrorism suspects, and it also included waterboarding. The article explores why the American Psychological Association made this decision, or why the doctors, the American Medical Association, did not go along with this and refused. So the principal reason given is that ethical guides or ethical codes are new to psychologists, even though they've had an association for a long time, but not new to physicians. And the reason for that they're not new to physicians is well known. You probably know already. In 1947, accused physicians tried to defend themselves with the excuse that they were only following the law. The court announced that a physician could not deviate from his ethical obligations even if legislation demands otherwise. The BMJ article I just showed you says the Nuremberg ethic should be central to all professions, not just medicine. Ethics codes may differ to reflect the difference of roles, but no one should escape personal ethical accountability merely by following state authority. The doctor's trial, as it was called, the first trial after World War II was the doctor's trial. And they produced the Nuremberg Code, which dealt with experimentation. Subsequently went on to the Declaration of Helsinki, will be developed from that. The Declaration of Geneva, which is an ethical statement similar to the Hippocratic Oath, and the Declaration of Tokyo, which deals with torture. Just to quote briefly from the Declaration of Geneva, I will practice my profession with conscience and dignity. The Declaration of Helsinki, the physician's knowledge and conscience are dedicated to the fulfilment of this duty. Now, previous ethics guides in the Medical Council included copies of the Declaration of Helsinki and the Declaration of Tokyo, and at least one guide had a reference to the Declaration of Geneva. These don't exist anymore. If you don't know about the doctor's trial, 7 doctors, German doctors, were hanged. So what doctors know about the past is not nice. So going on from that, I am suggesting that professionalism is not the answer. It's a pity about the light, but you can see 2 doctors here. This one over here is me. When I was asked to produce a picture when Karen rang me and said she wanted a picture, I got my secretary to take a picture with the iPhone. So I called her back. I said, I want to take another picture. And I got this one over here. You can see the outline broadly. And it was meant to be a sort of a mock-up of this picture here. So this very professional-looking doctor on the left is one of the doctors he never went on the doctor's trial because he escaped, Dr. Mengele, and he lived his life out in South America. In fact, he was an abortionist in South America and killed a woman, but he was able to get off. So going on from this ethical problem for young doctors who may not want to get involved in abortion, 2 possible solutions, one from Mary Stopes, 2 irreconcilable solutions. Our research published in The Lancet shows that nurses and paramedics in Vietnam and South Africa do the work extremely successfully, but they are not allowed to do it here. This is in the UK, and this must change. The Pro-Life Alliance suggested, we've been hearing for some time now that young doctors in particular do not want to work in this field. Those choosing to go into medicine presumably do so because they want to cure sickness and disease, not end the lives of innocent human beings. If you ask me, what contributed to this change in doctors' attitude towards termination of pregnancy, I think that the answer is in the development of ultrasound. This is Professor Stuart Campbell. It may be known to some of you. He's retired now. Seems to have undergone some sort of a change of opinion himself with the advent of 3D ultrasound. He said there's something deeply moving about the image of a baby cocooned inside the womb. And he did campaign for a reduction in the abortion age in the UK unsuccessfully. Got a bit of grief for it. The ultrasound thing, just as a last thing, people have started writing books about it, and this is a book written by a woman called Catherine Mills. She says, if there's anything that, she's a pro-choice person, if there's anything that would lead me to an anti-abortion position, it is the capacity to see the fetus, particularly as it performing activities normally associated with babies, such as thumb sucking and so on. So anyway, I've had my little piece about conscience and ethics, and I will conclude by making the following observations. There is a rise in mortality, in maternal mortality in Western countries. I don't see any sign of it in Ireland as yet, but it may be that it is to come, and it's of interest after 50 years of stability. Sepsis has re-emerged as the leading cause of maternal mortality in the UK. I'm suggesting that maternal mortality may be related to lower recruitment into obstetrics and gynaecology. And in Sudan and in Northwick Park and in Dublin, I'm suggesting that maternal mortality is related to simple clinical measures, blood, antibiotics. It is not to do with highly complex procedures. Many maternal deaths occur from the same reasons as they did 50 years ago. And there is no evidence that abortion is of benefit to maternal mortality, and I would suggest that the opposite is much more likely. So thank you for your attention.